Hi, I'm Emma, one of the orthopedic registrars. So today I will be going through upper limb injuries, but we'll mainly be focusing on different types of immobilization, the pre and post-op care, and also dangers. There are lots of dangers in the upper limb, so we'll go through them systematically. So today's objectives, as mentioned, will focus on the upper limb, all the way from the collarbone all the way to the wrist, discuss different operations just for your interest, but we're mainly focusing on the dangers of the upper limb, neurovascular observations and elevation. So upper limb cases as inpatients, because this course is focusing on ward patients. So a lot of our upper limb patients, they're actually managed as an outpatient, and most of them go home from A&E. So you may not necessarily see them acutely on the ward all the time. They are managed via our fracture clinic, either with conservative management with things like plasters and slings, or they go home and they come in for surgery another day. The patients that are actually admitted from the upper limb cohort is usually patients with open fractures, if they have neurovascular compromise, which we'll go through a lot today, and if they have polytrauma, which means they've got more than one injury. And they are also managed either conservatively with plasters and slings or surgically via an operation. So the upper limb fractures, so we cover everything from the clavicle, which is also known as a collarbone, all the way down to the hand and the wrist, and we'll go through them like this today. Just before we get onto the bones, some important pre and post-op upper limb dangers is number one, swelling. So whether you've got a proximal humerus fracture up here, or you've got a distal radius fracture down here, the upper limb, or any limb, to be honest, swells up majorly. If you have any fracture, you need to make sure you're taking off the rings. You can see this ring finger here, it's already swollen distally from the ring. This can cause catastrophic dangers. It stops blood getting down here. This finger can become ischemic and have to be amputated as a worst case scenario. So swelling, please remove all the slings, or the rings even, not the slings. Number two, dangers, nerve injuries. We'll see today that there's many nerves going down the arm, and they get in the way of lots of fractures, and they get in the way of the operations. If you have any nerve injury, they can cause numbness in the hand. They can cause weakness in certain movements as well. And the last one is blood vessel injury. So it's really important to always check the patient has a pulse. So you're checking here for the radial pulse and here for the ulnar pulse. So both sides are important for every upper limb fracture. So bear those things in mind: swelling, nerve injuries, blood vessel injuries. So why do we do neurovascular obs? So you may have seen on our operative notes, it will say neurovascular obs for the upper limb, or coming in from A&E, we'll say neurovascular obs. So what does this mean for the upper limb? This is your bone structure, as I've shown here, just on the left of the screen. And in the middle, this picture now, it shows all of the nerves in yellow, the veins in blue, and the arteries in red. So you can see, although our first picture looks quite nice, yeah, we can fix the bone here with a metal plate or wires. Actually, you've got all of these structures which are dangerous, blocking the way, and we have to be very careful operating. Not only do you have to be careful operating, but the fracture itself can bend and displace in a certain way that it squashes these blood vessels and nerves, causing problems. So the dangers, as mentioned, are nerve injuries, which cause numbness and weakness, and arterial injuries, which cause no pulse, and this is an emergency. Neurovascular obs are most important in the first 24 to 48 hours after the injury, and also the first 24 to 40 hours after an operation, because these are the most times when swelling can occur. So neurovascular observations, what are they? So we'll go through the nerves of the upper arm, and go through their movement that you should check, their sensation that you should check, what happens when there's a nerve injury, and the common fractures that cause this. So the radial nerve. So the movement that you test for this is you test wrist extension. So can they lift their wrist up? So you can see this person's right hand is working normally, the wrist is upwards, radial nerve is functioning, but their left wrist, they have something called wrist drop. They're unable to extend their wrist, and this is for the radial nerve function. For sensation, for the radial nerve, you check at the back. So usually the first web space here is the best space. You check that and compare it to the other side. So if they have a nerve injury of the radial nerve, they will have wrist drop and they will have numbness in their first dorsal web space. The most common fractures that radial nerves injuries occur is in humeral shaft fractures, which I'll show you soon, and also distal humerus, so just a bit lower down. So just take a moment and just think of what you're going to do for the radial nerve. Just two things. Can you lift your wrist up? And can you feel me touching your hand at the back of just near your thumb? That's it, just those two. All right, now for the median nerve. So for the median nerve function, you can do opposition. So thumb touching the index finger. And you can do thumb abduction, which is quite sensitive for the median nerve. Sensation. Median nerve is the palmar aspect. So it's the thumb, the index finger, the middle finger, and half of the ring finger. So going down there, this is all median nerve. This is when you hear people have carpal tunnel syndrome. That's compression of the median nerve. So any numbness or pins and needles in the thumb, index, ring, and middle and half of the ring would be a median nerve symptom. What does it cause? Unable to do certain thumb movements such as abduction, because that's quite sensitive for the median nerve. And as mentioned, numbness in the 3.5 fingers. This is common in distal radius fractures. So the median nerve is here in the carpal tunnel. It's traveling up that way. So if you have a distal radius fracture, it can press on the nerve and it causes pins and needles and 3.5 digits and difficulty with opposition and some thumb movements. Anterior interosseous nerve. This one is a purely motor nerve. There's no sensory component. And the best way to test it is asking them to do an OK sign. So the anterior interosseous nerve, in particular, it bends the end of the thumb and it bends the end of the finger, forming your OK sign. So that's the only thing for anterior interosseous. If there's a nerve injury, they cannot make an OK sign. And the most common injuries with that are supracondylar fractures, which you see in children. Supracondylar is just above the elbow, just about there. And radial radius bone fractures, so about here, proximal ones. So that's the only thing for ulnar nerve. Okay, ulnar nerve. So the ulnar nerve, I always ask them to make a big star with their fingers, and then can they cross their fingers over? So big star and then cross them over. Sensation is the leftover bits from the palmar bit. So it's half of the ring and the whole of the little one. So mainly we just check the little one, it's most sensitive. If you have an injury to the ulnar nerve, someone will present with a claw hand, which looks like this picture there. So claw of the 4th and the 5th finger, and they have numbness in the 5th and the 4th finger. These commonly affect elbow fractures and ulnar fractures because the nerve runs along there. So this is quite a good summary table. So if you just remember these 4 movements, you'll be able to test every nerve, and you just need to check 3 different places for sensation. So radial is just, can you lift your wrist up? Can you feel in the first dorsal web space? Median, can you oppose your thumb okay? And can you feel on the index, thumb, and middle finger? Anterior interosseous nerve, can you make an okay sign? And ulnar nerve, make a big star, cross your fingers, and can you feel on your little finger? That's that would be quite a thorough neurovascular observations for the hand if you're able to post-operatively. So as we're focusing quite a bit on immobilization, anyone want to put in the chat what type of immobilization this is?
All right, people are starting to type. We have sling, sling, polysling, polysling again. I think it's a unanimous decision. Mostly people typing polysling.
All right, great.
Someone said master sling.
So this is a polysling. And what we'll go through now is which type of fractures you'll use a polysling for. So the first one, you use them for clavicle fractures. So these are very common fractures. They can happen to all ages, from children all the way up to elderly. This is an X-ray here of a clavicle fracture. You can see the broken aspect is just right in the middle of the bone. On the ward, you'll see the patients using a polysling, which is like the picture I've just shown. They will most likely be more comfortable sitting up. They'll be unable to lie down fully due to pain from the fracture. And the clavicle is very closely related to the lungs just here. So they may find breathing quite painful. So if you take a deep breath in, you notice your clavicle, your whole shoulders move up, and breathing will be painful with the clavicle fracture. The treatment for this is regular analgesia to help them with their breathing and also help them get comfortable with their position. They're a polysling and some require operation. So this is a polysling again. So by using a polysling, it offers a lot of support to the forearm and the elbow. It can take the whole weight of the arm. The benefits of taking the whole weight of the arm is it can relax the muscles around the clavicle and help keep the clavicle, if possible, in a suitable position. Some require operations, and this is one of the operations that we do with a metal clavicle plate and screws. These plates can stay in forever. They don't have to be removed unless they start to irritate. They can start to irritate across a bra strap or holding a rucksack, in which case we do remove them. So that's the clavicle. The dangers with the clavicle fractures, as you can see in this picture, this spike is extremely close to the skin. So it's really important to check the skin on your physical examination. So you can see this side, so the patient's left, that's what the clavicle fracture is. There's extreme tenting of the skin here if you compare it to the normal right side. And what can happen is the wound, well, the skin can tent so much that it creates a wound or a blister which opens up, and essentially it can cause an open fracture, which has much more complications associated with it. So do always check the skin and tell them to relax their arm in that polysling to take all the weight. If there's any threat to the skin, then we may admit them for closer observations. So number 2, scapular fractures. They also use polyslings. These are quite uncommon fractures. They are high impact, so usually associated with trauma calls and seen more in trauma centers than DGH hospitals. Again, they use polyslings, so it helps take the weight of the arm. As you can imagine, the weight from the humeral head downwards needs to be relaxed. In this case, it's an intra-articular scapular fracture. So by stopping movement of the shoulder, it will help with some of the pain relief. Again, they will be unable to lay down fully, mainly due to pain. So they'll be sitting up as well, and just let them sit up. They may have to sleep sitting up as well, they will. And breathing again may be painful. The scapula does move when we take deep breaths. For regular analgesia is the management. The reason we say regular analgesia is if you could make someone more comfortable breathing, they'll be less likely to develop atelectasis and less likely to develop pneumonias. When someone's not clearing their lungs properly, these are some of the risks. So again, polyslings help relax the whole arm, and some require operations, and these are really large operations. I'm going to show some pictures now. So if you're not good with the operative pictures, then you might want to close your eyes now. So this is the back. This is someone's scapula just drawn on their skin, and it's quite a big incision that we have to make a flap which comes off, and you can see all of the muscles right there. We then replace we fixate the fractures with these large metal plates, so it goes round in kind of this LC shaped, and another straight one there. Again, they can stay in forever, don't have to be removed unless they're causing any problems. So that's the scapula. Anyone know what this immobilization is called?
All right, we're having a few replies, all along the same lines: collar and cuff, collar, C and C. I assume it's not cookies and cream and collar and cuff, but yeah.
All right, great. So yeah, you're all correct. That's the collar and cuff. So collar and cuffs work differently to polyslings, and that's why we use them for different fractures. So you can see here the collar and cuff is supported around the neck, and it's also supported around the wrist. This means that the whole of the patient's weight of the arm is hanging down with gravity. So if there's a fracture up here, the proximal humerus, the elbow will be hanging down and hopefully be aligning the fracture a bit better. We advise you not to put any pillows underneath the elbow of someone with a collar and cuff. The reason being, if you have a proximal humerus fracture, we need the gravity to be aligning the fracture. As soon as you put pillows up here, you're going to start pushing this bit this way, this bit this way, and the alignment will go. So collar and cuffs are used for proximal humerus fractures. They are extremely common. They mainly happen in the elderly population, and you'll see lots of inpatients with these proximal humerus fractures. On the ward, you'll see them with the collar and cuff. They'll be sitting up as well, unable to lie down. It's a common theme with the upper arm fractures, mainly due to pain. Treatment, regular analgesia, again, a common theme. Collar and cuff can be a definitive treatment for some fractures which are still well aligned. So at the top here, there's a fracture here, proximal humerus fracture about there. It looks like actually the greater tuberosity is also fractured off. Whereas if you compare it to the X-ray below, you can see there's extreme displacement there. So this is the humeral shaft, which should be here. So that's very displaced. I'll show you in a picture in a minute, but here there's important blood vessels and there's important nerves. So if you imagine that shaft is supposed to be here, it's potentially squashing those structures and causing danger for the upper limb. So some are treated in collar and cuff, so not the polysling. This is just to show you a comparison. So you can compare where the elbow sits in a collar and cuff, where the elbow sits in a polysling. Got much more gravity effect with the collar and cuff. These are some of the types of operations for your own interest. So the picture on the left, this is a metal plate and screws, which are used for proximal humerus fractures. And the picture on the right, this is an intramedullary nail with screws. So those are a couple of options we can do. Replacements are also an option if the humeral head is in too many pieces. So dangers and why we ask you to do neurovascular status observations. So as I mentioned, there's some important structures around here. So all these yellow bits are nerves. So you've got the axillary nerve, which actually wraps around just below the head of the humerus, just here. And that's one of the structures at risk with proximal humerus fractures. You can also see there musculocutaneous nerve, median nerve, ulnar nerve a bit further away, and you've got the axillary artery, this big red structure there. So our main dangers for proximal humerus fractures are axillary artery injury. So axillary artery is just there. You saw in the X-ray that the humeral shaft, this bit here, had displaced inwards. And you can imagine now how that's very closely related and can be squashed by the fracture. That's an emergency if there's no blood getting distally and has to be resolved extremely quickly. The other danger is the axillary nerve. So as I said, it wraps around the proximal humerus there. The axillary nerve is responsible for sensation in what we call the regimental badge area. So to check that, you just check just on the side, so just about here, if the patient can feel normally, and compare it to the other side. So proximal humerus, remember to check the pulses and check sensation in what we call C5, regimental badge area. Anyone know what this immobilization is?
And while we wait for the answers, a regimental badge comes from the military. So it's the place where the military usually had their grades and their rankings placed on the badge of the Delta. But yeah. So we have a few answers: humeral brace, shoulder humeral brace.
So perhaps this one is slightly more unfamiliar. So yeah, for those of you who said humeral brace, that's the correct answer. So this is the humeral brace aspect, which wraps all the way around the chest and to the back. We obviously don't want the arm to be dangling down, so it's also got a collar and cuff aspect, but all of this is part of a humeral brace. So as the name suggests, we use humeral braces for humerus fractures, in particular the humeral shaft. It's quite common, happens more in younger adults. It's a common injury with arm wrestlers because of the twisting forces on the humerus. On the ward, so when patients come to A&E out of hours, we don't usually have humeral braces in stock. So they will be given something called a U-slab. This is here. So it's quite a big and bulky and heavy contraption, but you've got the plaster coming here, going round the elbow and then up here towards the armpit. And again, you've got the collar and cuff aspect. This is a temporary measure. So you'd put the patient in a U-slab overnight until you can get a humeral brace the next morning. For those of you who have humeral braces in your A&E, you're lucky. But the humeral brace is much more comfortable, as you can see, much more lightweight. So the thing to bear in mind with humeral shaft fractures, there's, as you know, lots of nerves and blood vessels. So you have to document the neurovascular status before you put plaster on, and also after you put plaster on. And same going for this neurovascular status before the brace and document it after the brace. Things can change. There's a nerve, which I'll show you in a minute, which can actually get trapped in humeral shaft fractures. It can be not trapped when the injury happens, but it can become trapped with braces or plaster. So it's extremely important to know what's changed, and if your intervention has caused a nerve palsy, then you do need to remove it, reassess the patient, and then go from there. So again, on the ward, patients sitting up, they won't be able to lay down flat, so they'll be sleeping sitting up as well. Regular analgesia, this is very common, very painful, the humerus fractures. Essentially, your upper arm is up here, there's a big fracture about there, and the rest of your arm is just kind of hanging with gravity. So it's every movement is extremely painful. Regular analgesia, and again, they're either treated with humeral braces for their definitive treatment or by having surgery. So dangers and importance of the neurovascular status, as mentioned, this is the radial nerve, which we discussed earlier, how to test its function. And it wraps around the humeral shaft, and it can get trapped, just as this picture demonstrates, inside the fracture. Now, as I said, that can happen at the injury time or the immobilization time. So the dangers are the radial nerve injury, which will cause a patient to have a wrist drop. They will not be able to lift their wrist up and have numbness in the first dorsal web space. That's the first dorsal web space area. And that's another demonstration of wrist drop. Anyone know what this is? So this should be a bit more familiar.
All right.
Is that a regular cast?
Some people said cast. I think there was a voice also chatting and saying cast. Back slab, above elbow POP from one of the AMPs in A&E. Cast, back slab, cast. All
right, so yeah, I mean, it's a bit hard from this picture to see if it's a full cast or a back slab, but the main thing to take away from this is it's an above elbow back slab. So some fractures will be treated with above elbow plaster, and some fractures will be treated with, sorry, one sec. There, some fractures will be treated with below elbow plasters. We'll go through the differentiation now. So this is an elbow fracture. This is one which is quite common. It can happen in all ages and low and high impact. This is the olecranon. So this is what we call an olecranon fracture. This fracture has stayed in a relatively good place. For this patient, you have an above elbow back slab, as I showed. Could have a polysling, and they may have a brace on the elbow. So if you look at the x-ray now shown, you can see compared to the first x-ray where it was a simple olecranon fracture undisplaced, this is much worse. So there's here fractures of the olecranon and it's displaced. There looks like a coronoid fracture there. And you can see the elbow is not really in continuity as it should be. So we treat them with the above elbow back slabs. This is a hinge elbow brace. So not usually given straight away after injury, but you may see patients in clinic with this. This is a type of fixation that we do for the elbow. So this is for us an olecranon fracture. This is what we call a tension band wire. So you may see patients who come in through the surgical assessment unit or the wards for day surgery. This is a tension band wire. And this is something a bit more extreme. So this is when the fractures are much worse. And sometimes it looks like there's more metal than bone on there. We've got 2 humeral plates here, lots of screws, and this is an olecranon plate as well. So you can see the elbow fractures come in quite a wide range, can be simple and can be extreme. But your main things to take away from this are to use back slabs above elbow, to use poly slings to help hold the arm, and regular analgesia. The dangers and importance of the elbow. So you've seen this picture before. Elbow joint is about here. And as you can see in that area, unfortunately, there's lots of nerves. In yellow, there's lots of blood vessels, which are quite large, the arteries and also the veins. So have to be careful at the time of injury and also during surgery. So dangers for the elbow are all of the nerves, the median, radial, ulnar, and anterior interosseous nerve, and the brachial artery, which is the big artery is going across your elbow. So I bring you back to this slide, which is for the neurovascular observations, and you want to check all of the nerves, sensation and motor for the elbow injuries. Pre and post-op dangers with elbow fractures. So they can swell up quite a lot. They can cause blisters and they can cause open wounds. So blisters from the injury or blisters from the cast. So although olecranon fractures can sometimes be simple, I always take off the plaster if I see a patient who's come from another hospital and I check the skin myself. There can often be a hidden open wound or a blister which is not looking very healthy. Anyone know what this immobilization is?
Give it a few seconds. I'm sure people will type up the right answer. So we've had Bradford sling, Bradford. Yeah, Bradford again. I think it's a general consensus for Bradford.
All right, great. Perfect. So yes, this is what we call a Bradford sling. You'll see this on lots of our operation notes, and also on patients who are admitted from A&E, we often put them in Bradford slings. This is the thing that can give us a high elevation, which helps drain any swelling from the hand, the wrist, and the forearm. So we use this Bradford sling for radius and ulnar fractures. So this X-ray is showing you there's a radius and ulnar fracture, and actually it's bent backwards quite a lot. So if you imagine all those nerves are coming this way and the blood vessels, and there's some all the way back here, and they're being bent and tented by this fracture. So now you can see why neurovascular observations are so important. For these patients, we give them an above elbow back slab as well. So don't give them a below elbow because it will not support the whole radius and ulnar. And it also doesn't stop someone twisting, supination, pronation. So you do have to immobilize the joint below and the joint above for the forearm. Again, you give them a poly sling just for comfort and to help them with keeping their arm up. And when we admit them, because we usually admit the both bone forearm fractures, we ask for high elevation in a Bradford sling. This is extremely important. If you don't have a Bradford sling, then we have seen people make quite very good Bradford slings out of pillowcases and a drip stand. So whatever you can do, putting someone in high elevation for forearm fractures and distal radius fractures can make a world of difference. As soon as there's too much swelling, the nerves are compromised, the blood vessels are compromised. It's not a situation you really want to be in. So they can be managed if in a suitable position, and some with children with back slabs and plasters, but otherwise usually we do surgery for these. This is an X-ray which shows the operation that we do. So there's a metal plate and screws here on the radius and a metal plate and screws here on the ulna. Again, they can stay in forever unless they start causing irritation. The ulna is your bone just here. So if you follow your little finger down, it's that bit there. So you can feel there's not actually much fat around the area. So sometimes the plate can be a bit prominent. the dangers and importance of neurovascular status. So I know we're highlighting on this today. So with our radius and our ulnar fractures, so here, ulnar bone, radius bone, you can see here there's a median nerve just right close by. There's the ulnar nerve right close by. So they're higher risk of being injured. If you look at the red structures on the other picture, you've got blood vessels, the radial artery, the ulnar artery, they're both at risk of being squashed, injured, compressed. So dangers wise, everything I mentioned, median ulnar nerves, radial ulnar arteries. So you want to go back to our table and how you do neurovascular obs and check your median nerve function with thumb opposition and thumb abduction. Check the sensation in the thumb, index, ring. And with your ulnar nerve, big star, so abduction, adduction, and cross the fingers, and sensation in the little finger and half of the ring. You want to check and document the pulse. So do you have a radial pulse? Do you have an ulnar pulse? And the capillary refill time. So this is a patient, a danger which can happen. So someone with both bone, forearm fractures, that means a fracture of the radius and also a fracture of the ulnar. They're screaming in pain despite having lots of oromorph. Why do you think that is? Do you think it's normal pain from the fracture? Do you think it's because of an open fracture, or do you think it's because of compartment syndrome? Oh, great. So yeah, you're all correct. Compartment syndrome. This is one of the reasons we ask for high elevation. In the forearm, breaking the radius and the ulnar can cause quite a lot of impact on the soft tissues around it, the muscles and the compartment. So you want to decrease the swelling as much as you can. This is why we also normally admit both bone forearm fractures for high elevation and observation. So compartment syndrome, the only symptom of compartment syndrome is pain. By the time you get to pulselessness and paresthesia, it's too late. So the only symptom to be concerned of for compartment syndrome is pain. It's when the pressure in the muscular compartments get too high and it squashes all the blood vessels. It stops blood getting out and it stops good oxygenated blood getting in, and the muscles die. Gory picture coming up, so close your eyes if needed. This is a fasciotomy for the upper arm, well, for the upper limb. So to actually open up the compartments and release all the pressure, you have to make a big incision from the elbow all the way to the wrist. So it's something that's an emergency, and we carry out very quickly if suspected. So this is why neurovascular obs are important. So now down to the wrist fractures. So this is a distal radius fracture. You can see the fracture just going along here. This is very common, happen in all ages. Some patients will be admitted for this if we're worried about the neurovascular status. Some patients go home with this if the alignment is satisfactory. For these patients, you can give them a below elbow back slab. They don't need to be above elbow, and a polysling to help just with the elevation aspect. Regular analgesia, back slab, some need surgery, and high elevation. This is a back slab below elbow for the distal radius fractures. These are some of the operative fixations that we can do. So we can put wires in. These are called K-wires. They just stay in for about 4 to 6 weeks, and we can pull them out in clinic. The patient doesn't have to come back to theatre. This is a distal radius plate. So this is a plate and screws, again, staying forever. It's quite usually low profile. Unless it causes problems, we remove it. Bradford sling, high elevation, time of injury, and also post-operatively. Dangers and importance of the neurovascular status. So this is a sideways picture of the radius and the ulna. This is where your distal radius has broken, here. But the distal radius here is what's supposed to be sitting on the top. So it's completely dropped down and backwards. Now, this is where the median nerve usually is. So the median nerve is coming up nicely here. As soon as it hits this spike of radius bone, it's going to tenter around it and then go back in. So this is extremely concerning for the median nerve in particular. And I wouldn't be surprised if the patient had pins and needles in the thumb, index, and ring finger and had difficulty with movement. This one needs immediate reduction in the emergency department to get a much better position and to stop the tenting of the median nerve and relieve the symptoms. That's just to remind you about your neurovascular ops. So other upper limb admissions which are not fractures. So you may see this. So this is redness along an elbow. Anyone know what this is?
All right, we'll give it a few more seconds. We've been having a few typing in cellulitis, infection, osteomyelitis, cellulitis.
All right, so yeah, this is cellulitis. So it's an infection of the skin. Someone said boil. So yeah, potentially there could be a boil here, which is caused and expanded to a skin cellulitis infection. You can't tell from looking at this picture, this is osteomyelitis. Osteomyelitis is a bone infection, which you can only actually really tell from an MRI scan. But there are some X-ray changes, but they're not usually acute. It's usually after long-term osteomyelitis. So again, these patients as well, we ask for high elevation. So anything that can swell up, we ask for high elevation. Mark the redness with a marker pen so that every day we can see whether the antibiotics are working, and you give them IV antibiotics. This is another condition here. This is what we call olecranon bursitis. So you can see the elbow, it's quite bumpy here, and there's a little bit of redness, but olecranon bursitis can be caused from an infection as well and can cause cellulitis like this. This is what the bursa is. So just below the olecranon, there's this kind of pillow kind of structure called the bursa. You've got them in your knees, you've got them in the elbows, and they can become inflamed. Sometimes people get scratched around their elbow, or they'll get an insect bite, and then it will cause inflammation and infection around the bursa and cellulitis. So yeah, these ones need high elevation to get the swelling down. You'll be surprised at how much the swelling can spread in the upper limb. So even though it's an olecranon injury, they can get swelling all the way up to the wrist. And if you don't elevate, they'll have swelling of the whole hand and fingers as well. So this is for general instructions for the upper arm. So as mentioned earlier, when you have a collar on a cuff, which this is, they're used for the proximal humerus fractures. And as I said, we need gravity to be pulling down the rest of the humerus to align the proximal humerus fracture. So no pillows under the elbow. It will push up the fracture and displace it. Upper arm fractures and injuries, they're just going to want to sit up. So just let them sit up, let them sleep upright. Either they'll sleep in a chair or they'll need lots of pillows behind their back. For the lower arm, so the elbow downwards, for elevation, the best thing is Bradford sling. If someone's sleeping, they can sleep with the Bradford sling, or you can put pillows underneath their elbow, but you need to make sure the fingers are higher than the elbow. So the fingers are like this, so it's always draining backwards. This is a poly sling, as we mentioned. So any fracture of the forearms, the distal radius, even the hand, the poly sling will act as an elevator. So you just want to tighten up the top strap to bring the fingers higher than the elbow again. So come to the end of the talk, just on time, 8:45. So hopefully you've been able to learn about common upper limb injuries, fractures, and also non-fractures. Be aware of some common operations that we do, but only for your interest. It's not one of the major aims here, but know how to check neurovascular status, extremely important for the upper limb, and be aware of some of the nerve and blood vessel complications.